So I'm Debbie Givens, and I am the chair of a task force that puts on these seminars monthly. And I have a wonderful crew that helps me with planning these. I am the recent past chair of the Research Intensive Programs in Physical Therapy. It's a consortium of ACAP, the American Council of Physical Therapy, Academy of Physical Therapy. I also want to acknowledge that Mary Shaw is here, and she's the current chair of ACAPT, and she's waving there. And so we put on a number of seminars that I'll point out on our consortium page that you could go back and review from last year. This was the brainchild of the ACAP leadership to help us keep moving forward and connected during the COVID pandemic. And it's been so wildly successful. We've been continuing this. And this year we decided to create the theme of how research informs practice and practice informs research. And before I introduce our speaker, for those of you who are going to be in San Antonio in February, I want to let you know that the consortium has a business meeting on Friday evening at 5 o'clock, and it'll be at the Marriott River Center in Salon B. We have a PhD postdoc mixer in that follows in Salon C. We co-host that every year with the Academy of Research and ACAPT. And then also our colleagues, and I think Carol Tucker is here tonight. There she is. Yes. And she is one of the people who is going to give a presentation on Saturday morning at the Grand Hyatt on the value of postdoc professional residency, fellowship, and PhD training. And I also want to give a shout out to Louise Thoma, Chris Lane, who did a podcast on why you should get a PhD for APTA. And it was in the top 5 of popular podcasts last year. It was number 2 out of the 5. So we are hitting a number of fronts on how to further your education and research and things like that. Before I introduce our speaker, just to let you know that if you enjoy tonight's talk, or if you think somebody else should hear it, if you Google RIPPT, RIPPT consortium, you'll come to our page, and what you can see is that our seminar series is advertised here, and every single webinar ends up being recorded. This one is being recorded tonight, and you can go back through them and listen to them. They're all on ultimately recorded on YouTube by our wonderful staff, Jamil. And so this takes maybe a couple of weeks sometimes for us to get them up, but you can always tell someone, hey, I saw something really great, or I want to go and check out maybe the other ones that have been done, and you're welcome to go to our page and check these out. But so that you all get the benefit of hearing our wonderful speaker tonight, we have Christine McDonough from the University of Pittsburgh. And you can see under her bio that she has a bachelor's degree from the University of Vermont. She did a PhD in evaluative clinical sciences from Dartmouth. And so that I don't take any more of her wonderful time, I'm going to stop sharing my screen and let Dr. McDonough continue.
Thank you. Okay, I'm going to try to share the correct screen. Let's see how I do. Am I sharing?
Yes, ma'am.
All right. It's good to see everyone. Thank you so much for having me. I really appreciate it. And I hope that I can share something of value to you all. When I was asked to come and talk with you, what I was thinking about was really the main efforts that I have in my work to connect research to practice. And 2 big areas are, what do we have here? Oh, here we are. And 2 big, sorry, I don't know why that started there. 2 of the big areas where this really is a big part of my work are in return to work rehabilitation, and in the areas of falls. So I'm going to just focus on the area of fall risk management and secondary fall prevention in this talk, and try to illustrate some of the work that I'm doing to try to connect those areas. And so, let's see if I can get clicking. I have no real disclosures for this. These are the objectives that we had posted, and thinking about linking health services research and other types of research with clinical practice. And also one of my goals is to just highlight some really, really great resources for people who are interested in making these kinds of linkages. So we'll talk about that later. One of the things that I have been really spending time thinking about is this concept of learning health systems, which is not new, but came as a result of really big discoveries about the gap between evidence and practice, and highlighted by the Institute of Medicine. Learning health systems really, this particular figure is modified from a McLaughlin paper, but I've kind of modified it based on the way that I'm thinking about how I'm trying to connect research to practice. And so just in the outside wheel, just to orient us, we have taking data and transforming it into knowledge. And that's the evidence part of learning health systems. And then on the right is practice, which is taking knowledge and converting it into performance in the clinic. And then down at the bottom, it's transforming performance into data. And so those are kind of the main areas I think about how this might work from a learning health systems perspective, and what kinds of activities I'm doing. What you could see, like if we just take the performance to data pie slice, you can sort of see on the outside would be data systems and interoperability, which would be kind of the outer ring of things we need in order to transform actual clinical services and performance into data. And then that can be transformed into clinical registries and benchmarking. And to get close to the center, the patient, those capabilities get transformed into something like a clinical dashboard that can actually impact clinical decision-making in practice. What I'm going to start with, though, is over here from data to knowledge, the business of conducting trials, synthesizing that information, and developing clinical practice guidelines. So in this particular area that I'm trying to link, it's fall-related injuries, which, I think most people are pretty clear about how devastating they are for older adults. The thing that I would highlight among all of the evidence is that 80 to 95% of fractures in older adults are related to falls. So that's kind of the part that I'm focusing on. And that's evidence that, that's sort of well established through health services research. Another really important piece of information is that prior fall-related injury dramatically increases risk of subsequent fractures and death. And so that's sort of a motivating factor for me. And then what I wanted to just do is focus on kind of one of the ways that I interacted with this evidence to help by creating a clinical practice guideline. And so I worked with the team for the Academy of Geriatric Physical Therapy to develop a clinical guideline. This particular guideline was developed based on existing clinical practice guidelines, which is kind of beyond the scope of this talk, but I want to use that as an example to show how we synthesize the data to create this guideline to guide clinical practice with the hope of changing this. And a couple of examples of some of the recommendations that came out of this were, for example, physical therapists should routinely ask older adult patients if they have fallen in the last 12 months. That's just an example that was based on level 3 evidence. And then some examples of the fact that older people who report a fall should be screened with an actual instrument. A couple of other recommendations that are relevant to the kind of the next steps are that physical therapists must assess and document risk factors for falls and contribute to multidisciplinary management for people at risk. And that was based on a high quality clinical practice guideline. And then a couple of other ones are level 1 evidence-based strong recommendation for providing interventions individualized to address factors, and then clearly to provide balance training. So that's just sort of the evidence base. But I think what I was highlighting here is we were translating the evidence into an actionable guideline. And so the next step for me in terms of these, this particular problem and linking it to clinical practice was understanding a little bit about whether physical therapists were actually doing this, right? So we have this evidence and we have a clinical practice guideline. And so are they actually doing this, this work? And so what I did with, now this is particular now to health services research and observational research using large data. So I worked with a team at Dartmouth that I had connected with through my doctorate to investigate second fracture in older adults. And this was their multidisciplinary clinical research center in musculoskeletal health there. And this particular project was optimizing fracture outcomes. And it was Dr. Tossis, and she was my PhD advisor, and Bynum. And so whereas the methods are not of particular interest, in depth here, I did want to highlight kind of where we went to look at the data for this particular problem. So this was several studies that were based on Medicare beneficiaries aged 66 to 99. And we were looking at people who sustained a hip, shoulder, or wrist fragility fracture using Medicare Parts A and B, and then some particular stipulations in order to build the cohort. And then this part, this is one of the parts I think I guess I would highlight is that, knowing which files and how to use them was a particular area of expertise for people in these areas. So we use MedPAR, the carrier file, the outpatient hospital files, and then the assessment files for rehab. And there's a good deal of management of those files that has to be done, which I did not do myself, the team did. But just to give a sense of how we, put that cohort together using the Medicare data in all those files, we required a diagnosis and a treatment code. And we removed people who had already had a similar diagnosis and treatment code in the prior year. We applied a good number of rules to identify new fracture. And we excluded a bunch of things that you would want to exclude to make sure that these are kind of new fragility fractures. There were several studies. I'm only going to highlight kind of one just to give a feel for this large data set development and use for this question. This is the actual paper that was published. It was second fracture among older adults in the year following hip, shoulder, or wrist fracture. Basically we looked at 1 year for occurrence of fracture or death. And here I just wanted to show the cohort development because I just wanted to have a sense of how many people were in these data sets. So we produced, we had 24 million eligible people with eligible fracture. We ultimately ended up with 161,000 people with hip fracture in that cohort. 38,000-ish with shoulder or proximal humerus fracture, and 75,000 with wrist. So I just thought to give a little sense of how big these cohorts were. And then we analyzed the data with time to event analysis, Cox proportional hazards models, looking at the relationship between the first fracture and other factors, and also the incidence of second fracture. And what we found was that, not surprisingly, hip fracture patients had higher comorbidities and higher percent dying 1 year from the index fracture. Women were more likely to have any fracture. And the gender imbalance was higher for wrist and shoulder than for hip, which becomes kind of important later. But this was just a little bit interesting to show that the second fracture, where the second fracture sort of essentially, regardless of where your first fracture was. So let's look at the first graph here, the index wrist, right? This is people with their first fracture is their wrist fracture. The whole kind of bottom line for this graph is that over 40% of that, so second fractures were hip fractures. And so this is true for all fractures, right? So no matter what fracture you're getting as an older person, the subsequent fracture is largely hip. And, you know, just underlines the importance and the, you know, kind of the criticalness of this issue, to me anyway. So that was really informative. Basically, within a year, 4.3% had a second fracture overall. But those numbers are really higher for subgroups of people, and age and comorbidity had strong effects, right? So some of those, the older and the people with more comorbidities had a much higher rate of having second fracture within 1 year. And essentially that fracture prevention is as important after humerus and wrist fractures for hip and for men as much as women. So just a little kind of walk down the health services path to see how falls and second fracture might be informing what we want to focus on. We did another study, which I'm just not going to highlight right now, but it's basically using that same cohort, but looking at medications and finding that essentially after a new fracture, there was some shift in types of medications people had, but overall, there was clearly no sign that people were trying to get rid of dangerous medications or risk enhancing medications for people with falls. So medications were a whole nother area that we looked at, but I'm not going to focus on that now, because what I then did with this team was look at, okay, well, if it's so important that people who have fallen and fractured are at such increased risk and that the likely next fracture is hip, we should be looking at these people when they fracture. So what we did was we used that cohort. We also know from the guidelines and from the evidence that intervention for high-risk people decreases their fall risk and their fall-related injury risk. So we went on to try to look at this for, so here we took the cohort and we just focused on wrist and proximal humerus fracture for outpatients. And that's a kind of a key point. We were just looking at people who will present in the outpatient environment, who will not present as kind of really complex and hospitalized. And what we did was we looked at the percent who were evaluated or treated for fall risk up to 6 months after the proximal humerus or wrist fracture, and predictors of receiving evaluation or treatment, which I'm not going to focus on. But here's the bottom line. Within 6 months after a new fracture, upper extremity fracture for older adults, which means they are at very high risk for subsequent falls and fractures, 10.7% received any evaluation or treatment for fall risk or gait. And then we had some factors that predicted it, which are not really the focus of my talk. But I just want to pause there. So for me, that connects, we know how high risk these people are. And we can see now that this research, at least from the standpoint of claims, which have limitations, but really 10% is a pretty low number. Even if that was a real underestimate, it's still not going to get you to a sort of a reasonable number of people receiving services that are appropriate. So that said to me, okay, just having that evidence out there, just having that guideline out there is not getting people to the kind of practice we need to get them to. So conclusion from that study were that this low rate of assessment and treatment after upper extremity fracture is the most important finding, marking a large missed opportunity to reduce future falls and associated functional loss. We then went on, because those data, I didn't highlight this, but you saw probably on the slides, those data were up to 2009. And just around 2010 were a bunch of incentives and programs and policies to support fall risk management and fall prevention assessment. So we reran the data, the analysis with data from 2010 to 2013 and found really just essentially very similar rates. And I will just say, I have yet to find someone to publish that. So that has not been deemed sort of publishable paper so far. So from there, to me, that really speaks to an opportunity to improve management and outcomes. And although I kind of mentioned the meds here, we didn't go over that study, but basically fragility fractures in older adults should be sentinel events triggering assessment of meds and evaluation and treatment of balance and mobility, and considering humerus, wrist, and hip fracture as equally predictive of second fracture. Whereas I think anecdotally, people think about hip fracture as a big sentinel event, whereas it's clear that these other fractures should be. So let me see, I think I probably need to click again. Hold on one second. All right, so then I wanted to just highlight one really big project that was funded by PCOR, which was multi-site, huge study with really senior and expert investigators in fall risk management and prevention. That was called the STRIDE study, strategies to reduce injuries and develop confidence in elders. And this was a really big effort to address this problem exactly. And it had essentially a multifactorial approach to fall risk management using a nurse, a trained kind of expert nurse, which we'll talk about a little bit more. But basically, this was a cluster randomized trial of multifactorial intervention in 86 primary care practices. And they had 5,451 individuals over 70 years of age that were at high risk of fall-related injuries, which is just a monumental project. The intervention was provided by trained nurses, and they had a standardized multifactorial assessment. And then they had, sort of developed specific recommendations based on some standardized protocols, evidence-based protocols. They used motivational interviewing with the older adult, and then they had the development and execution of individualized fall care plans. So really, a really comprehensive solution to this problem. They found that there were no difference in rates for the first adjudicated serious fall or hospitalization or death. And by adjudication, it means essentially that fall was validated through multiple ways. In the clinic, so there were two different approaches to finding these people and getting them into the program. And one was through the clinic visit. And in the clinic, 22,000 screenings were done. And that led to 5,700 positive screens, or 25%. So basically having to screen 22,000 people to get to these 5,000 or 6,000. But the main way that they executed this trial was through a central screening mechanism, which essentially they identified potentially eligible people in the practices and sent letters to them, and then had them kind of, I can't remember exactly, but they were either self-screened or I think it was completed materials and then were identified as positive. The bottom line that I'm kind of getting to here is that there were 226,000 letters sent, and that then 34,000 people screened positive, and then 32,000-ish people were sent the packet, and of those 5,500-ish were enrolled, right? So I guess I'm just bringing to the fore how the kind of the massiveness of the endeavor here. And it is a massive problem. So it's not inappropriate, but it's just a big nut to crack. So the participation rate here was 34%. Okay, so that to me, you know, I at the time that I was working on those health services research projects, I was kind of following STRIDE and thinking about how it was thoroughly addressing the evidence that we know, and yet what a big challenge it is to actually execute this in practice. So the enrollment yields were 3.6% and 10.5%. So that led me in my little teeny efforts and small world to think about a sort of a smaller, more focused approach. And what I am working on trying is this, this approach where we try to identify people with a new fracture and address those people. And the thinking from my perspective there is, it may be that it may be easier to implement if it's a sort of a higher risk, more targeted group. So that's kind of the thinking behind this. And now I'm sort of switching into the area of kind of data infrastructure and other parts of that wheel, which we'll talk about a little bit. But my thinking was the predominant model generally for falls was falls clinics, or kind of like the STRIDE trial, which is nurse-led primary care-based multifactorial programs. And so I wanted to focus on especially high-risk groups. The other thing I would say is I had experience at Dartmouth with their fall risk team, and they were approaching it using a falls clinic. And so I had some experience with trying it from a different level, which I think we can leave that for the discussion. But I had the sense that multifactorial kind of broad screening is a really tough thing to do the whole population. So that led me to think about focusing a little bit more on the highest risk, and to address that by trying to focus on the most sort of the largest impact across the board intervention, which ultimately is exercise. The biggest magnitude of effect comes from exercise. So I wanted to focus on just high risk and just exercise, knowing, as we said from the guideline before, that physical therapists should be doing multifactorial assessment for high risk patients. So now I just wanted to come back to the wheel, the kind of the learning health systems wheel, the way that I'm seeing it or the way that I've modified it, and say, now I'm moving over into this kind of knowledge to performance aspect of things, and interacting with data and computing systems, documentation and training, decision support, creating learning communities, not incentives, I should have not had that, and using the clinical practice guidelines that were developed over in the data to knowledge end to create an actual workflow, a pathway for having implementation of a guideline. So that's just sort of showing that this is the arena that I'm in right now with this pilot project that I'm about to sort of share with you. And so what we did to start with is, again, sort of health service research in a way, except from one perspective, it's really in the learning health system, it's just using performance data to create knowledge. This local data about the local health system. And so I partnered with the UPMC Wolf Center for Quality, Safety, and Innovation. And we essentially tried to use the methods that we had used in the Medicare analyses locally to see whether what we saw in the national picture was true in the health system, where we might try to actually make a change. Because it's a little hard to say to your local people that you're going to actually try to change their life, right? Clinicians, administrators, anybody, that this is a problem in the nation. Like, it needs to be a problem today for us. So we looked into the data and basically found the exact same rate of referral to physical or occupational therapy after an upper extremity fracture for outpatients. Again, we're not talking about trauma patients. So we analyzed the healthcare system, electronic record and administrative data, and found the same results. The only thing is, and I'm not so confident about the outcomes we had, but I saw much higher second fracture rates. So we're still kind of working through whether that was valid or not, but the actual referral data we're confident in. So as a result of that, we said, yep, this is a problem worth trying to address here. And I gathered some, I have an appointment in orthopedic surgery as well as physical therapy. So I partnered with a couple of orthopedic surgeons, one in the university physician practice setting, and one in sort of a separate practice, affiliated practice setting. And we essentially proposed this as a quality improvement project within the health system. I also applied for pilot funding from the Academy of Orthopedic Physical Therapy and received that funding. So this is sort of supported by the UPMC, as well as for the research aspects supported by the Academy of Orthopedic PT. So the project that we proposed was to investigate the feasibility and just preliminarily whether there's any sign of effect of creating an electronic best practice alert within the electronic health record system that would alert surgeons to the risk and kind of help to create a semi-automated physical therapy referral to get them to PT-based exercise. And so what we plan to do now, this is the part of the learning health system where now we're going to record all the aspects of care that we can and look at them. So we'll look at the responses to the best practice alert, whether people went forward and made referrals to physical therapy, or if not, why they didn't. Whether older adults actually went to PT, and whether when they went, the PT that they got was aligned with what the guideline says should happen. And the second aim is to look at the factors that impact the uptake of PT exercise for people that are known to be high risk. And so for that, we're going to do some qualitative research. We'll do focus groups, semi-structured interviews with older adults with a fracture, with PTs and surgeons. And we're going to include some administrators as well. So here's just a little graphic to display how we kind of are thinking about how we plan to go about this, how we propose to go about it. First would be training physical therapists in evidence-based exercise that aligns with guideline recommendations. And essentially, because UPMC was involved in the STRIDE trial, we have already sort of a system ready for that. Some of essentially the neurologic focused PTs trained for the STRIDE trial in OTAGO, the evidence-based program. So some of them were already trained. And what we did was we just sort of kind of revived that effort and had 30, all the neuro PTs in all kind of area practices receive the training. Now that was funded by the grant. meaning their time, their dedicated time to do that, and the small amount of money that it takes to get that certification, the online training. Then we also provided education to the physicians in 2 practices on how to manage the referral sets, the PT referral sets in the electronic record, and what to expect of the best practice alert. So after having that kind of training, basically the patients who are over 65 with fracture are identified via diagnosis and imaging codes in the electronic health system. And that triggers this best practice alert to the surgeon. So the best practice alert is fired, indicating the person is at risk, and do you want to have a referral? And the provider, the surgeon, can opt out and give a reason or execute the referral. And then the referral goes, essentially there's a way to kind of route that specifically so that it can be scheduled sort of automatically. And the referral coordinator matches the patient with a clinic that has a trained therapist, and there are plenty. And then hopefully the person goes, receives the care, the evidence-based treatment, and then we look back and assess outcomes, including all of the items we talked about before. And then added to that is having interviews with the main stakeholders to find out how it went. And so our progress to date is, and this is the part where, no, that sounds like something, reasonable to get done. And it is really, really hard. So there's lots we could talk about in just trying to do, essentially interact with a health system that has priorities for resources, and actually trying to get resources for creating a best practice alert, and then tracking and dealing with, essentially interacting with, resources such as schedulers and other things like that. We've got the workflow figured out. We've got the best practice alert developed, tested, and implemented, and we have the 30 PTs trained in the evidence-based practice. And this is just a little screenshot of, some of the way that the alert looks in the electronic health record. So our next steps are to interview older adults, PTs, surgeons, and some administrators, and analyze the best practice alert data and the PT treatment diary and documentation to see whether the interventions are concordant with guidelines, and then to assess fall-related injuries in the electronic health record and administrative data. So now this I think is, I'm trying to sort of show this is full circle now, right? Where we're creating the data, and now we're going to analyze it, and then we'll give feedback on that. And I'm not going to touch on that, but there's a whole area of natural language processing or artificial intelligence that I would hope to use to refine how we identify these people, so that we really always are getting the right people from the beginning. Some of the things that I know that we will learn when we talk with the therapists are issues, and the surgeons, issues around, and the patients, excuse me, when to initiate physical therapy, when to initiate balance training, how soon after this fracture, how to provide challenging balance training across the continuum, of recovery, when to discontinue it, because remember, these are very high risk people. So now it's sort of, how do you use that evidence base to define when you can hand people off to safe community-based, evidence-based fall prevention exercise programs. And what we hope to learn is the feasibility, referral patterns beyond ortho and PT, which we will not get from the data. We'll have to get that from interviews. For example, Did surgeons refer to fracture liaison service? Did PTs refer to MDs for cardiac or other of the other factors, polypharmacy, other factors that they can screen for, but are not inside the scope? And then barriers and facilitators. So hopefully I gave you a sense of kind of this interplay between health services research, research to develop clinical practice guidelines, and then efforts to use data systems to learn from interventions in clinic. The things that I am learning from doing it is that, you know, this kind really linking research to practice takes a whole bunch of different sets of teams with different expertise. And so that's becoming clearer as I do more of it, how many people across different parts of that wheel, you know, and each of those items is different kind of microsystems and groups and collaborators. The other thing that I would note is, for example, you might find that a health system is, you know, prioritizing the particular problem that's of interest, which is really necessary, but they might actually be interested in attacking it from a different angle. So one of the things that I noted was, for example, I was working with people at Dartmouth, and they had a few different approaches that they were working on. One was through emergency medical systems, one was through the emergency department, and one was through home care. So I think one real take-home message for me is that you really need learning communities in order to be able to kind of create a collaboration so that you can be targeting the place that you're most prepared to or interested in or invested in addressing. And so with that, I wanted to sort of note that all of this trajectory of work for me has been supported by different research groups and mentors, and also learning communities. And two really important learning communities for me have been the Learning Health Systems Rehabilitation Research Network, or LEARN, and COSTAR, the Center on Health Services Training and Research. I think that they both provide really complementary but different resources, and they both provide really incredible learning communities and collaborative communities. So I just wanted to cover a little bit what some of those resources are for people who are interested in learning health systems. LEARN was initially funded in June of 2020 and funded through 2025. And it's funded by the National Institutes of Health. And there are 8 health system partners that are integral to the LEARN system, and that they provide input throughout all aspects of the programs and activities. This is just a map of the different medical rehabilitation research networks, and it just shows where LEARN is based at Brown. LEARN is a collaboration between Brown, Boston University, and the University of Pittsburgh. And just to point out from the standpoint of LEARN, the AHRQ has a definition of learning health services researchers as embedded within a health system and collaborating with stakeholders to produce novel insights and evidence that can be rapidly implemented to improve outcomes of individuals and populations and health system performance. So that's an area that I'm really interested in and learning more about and working in. There are some research competency domains. There are research competencies. They've been published, and there are 33 of them, and they are essentially kind of grouped into these topics that might be of interest: taking a systems science approach, asking meaningful questions, applying appropriate research methods, capitalizing on informatics, championing research ethics, optimizing quality improvement and implementation science, and engaging stakeholders, health system leadership, and research management. Those are, all really rich areas, and there's a lot to learn there. So LEARN's mission is to improve the quality, outcomes, and value of rehabilitation care by fostering learning health systems research. And basically, LEARN has funding opportunities, which are essentially mentored scholars, mentored collaborations, which is called a scholar. The scholars actually get paired with a health system to be an embedded researcher. And that's a structure for creating that. And then there are also mentored pilot studies. LEARN has quite a bit of educational activity. They have webinars, rounds, they do symposia, and they have an annual institute, as well as a really cool stakeholder summit, which includes involvement of the health system partners. And they do consultations. And then there's the techniques development aspect of LEARN, which is where I do my work in LEARN. It's essentially, I'm working a lot on the rehabilitation researcher needs assessment right now. And then we develop use case examples for rehab and resources to match needs. So there's a huge learning database there. Just a little picture of some of the events and the people who have spoken. And the LEARN resource database that I just mentioned, that would, if you have any areas of interest here, this is a great opportunity to get started. And then here's a little slide just showing the pilot and scholar opportunities and the health system partners. And so then I wanted to just finish with a little bit of information about CoStar, which was funded since 2015, and it will be funded through 2025 at least. CoStar's mission is to train rehabilitation professionals in health services research that informs rehab practice, care delivery, and policy. And just a snapshot of, they have funded 4 postdoctoral fellows, 13 faculty fellows, 3 visiting scientists, 375,000 in pilot awards, 15 awards. And they do really special institutes, health services research institutes, and intensive workshops. So those are really great opportunities to learn and also to just develop your learning community. CoStar extends the model of supporting doctoral trainees and targets early career faculty. And it really does help bridge the gap between PhD completion and successful independent investigators. And it targets training to develop independent health services researchers. For the fellowship program, a range of opportunities exist. And the trainees are provided with mentorship, scholarship, travel support and information. And the fellows are awarded up to $60,000 a year with additional funds for travel. And that's to fund part-time work, research. And there are actually diversity targeted training opportunities in CoStar, which is very exciting. And that is made possible by Teresa Shireman, Director of Center of Dermatology and Healthcare Research at Brown. And then the pilot program provides funding for pilot research areas. There have been 15 pilot studies funded to date, and my health services research project was one of them. So I thank CoStar for that. It was within that larger group of projects, but it wasn't the project that I presented to you tonight. It was a slightly different project done with the Dartmouth MCRC. And then I just wanted to highlight the CoStar Institute, 2 of which were on implementation science, for those of you who are interested in that. But just to give a sense, while we had to shift to virtual in 2021, we had really tremendous participation, 176 attendees in the day one and 109 in day two. And that was a free institute with the proceedings were archived. Our 2022 institute is going to focus on rehabilitation payment models, and that's coming up. And then finally, I just wanted to highlight that CoStar has had 2 institutes on implementation science, really is an important focus of CoStar, along with other areas of health services research, and resources are archived for the past institutes. I have posted contact information for both Learn up the top here and then CoStar down at the bottom. And I welcome comments and discussion. Thank you.
Thank you, Christine. That was wonderful. I want to mention, I believe Chris Lane was the recipient of the CoStar Summer Fellowship, and he's here tonight. So shout out to
Yay, Chris.
and Louise Thomas, his PhD advisor.
Great.
So he can maybe, if anybody wants to know about what that process was like as well. One question I do have, while we're on that topic, although there's some really interesting things to talk about in your data, but we've been having a discussion at RIPPT about the DP, MDs can go for fellowship training and things like that without a PhD. What is the eligibility for doing some of these things in Learn and CoStar for people who have a DPT degree but are not pursuing a PhD? Are they eligible? Because we've been looking at that aspect of faculty as well in terms of fellowship training and things like that.
Right. I think that there is no exclusion and no requirement for a PhD. I think one of the things that that in CoStar projects or fellowships would care about is essentially the potential for the research itself and for the investigator. So I think if an investigator doesn't have a PhD, I would think that person would need to have a team that they're working in that could advance that work, so that that it's not an issue of when you want to go for external funding, because I think one of the goals would be to create that kind of opportunity. Okay,
thank you. So just that terminal degree is not one of the check boxes.
Correct.
Yeah. And I'll take point of privilege since I have the floor, and then I'll step back and allow other questions. But well, no, I'll be quiet. I'll let other people ask their questions. You can either raise your hand or put them in the chat. Let's see, Sam has a question, it looks like.
Yes, thank you so much, Dr. McDonough. Your pilot project is pretty amazing, because I love the informatics component and using the BPAs and just illuminating this framework of using data and putting into practice is pretty amazing. And I had a question about, historically BPAs have been fairly challenging for a lot of clinicians just because of the alert fatigue. And I'm just wondering if you would mind sharing that experience, maybe the share language, especially with the physicians having to be alerted and notified. Like, what was that like to convince them that, hey, this is gonna be good?
Yeah, no, it's a big issue. And that's why I think for me, this is just putting my toe in the water of what all the strategies need to be. This is a start. And I think one of the things that I like about it is that we will be able to follow kind of the data, but what I would say is the clinicians were really convinced that this was an important problem.
Yeah.
Whereas the health system kind of from the top down isn't saying this has to be done. The health system is supporting all of this activity. And so I only started with 2 practices, but the 2 practices just simply, this is clearly an important problem. Now, the other thing is that we don't actually obstruct the providers advance into their other work. So this BPA will not impede them. It shows up, but it doesn't stop them from doing another thing. So that's gonna, I think, be an important thing to keep them from being fatigued or bothered by it, or just, or kind of upset by it. But it also may trade off being less effective. They may, because they can bypass it, they may not use it. So this is what we'll have to find out. But I think there would be concern if and there was support for us to put a BPA that made them have to address it to move on. But that's not what we have in place, partly because there was an advance in the methods in EPIC itself. But I will say that that's what we're going to learn is exactly what happens. And I think that's more the important point, right? Is like, if it is competing too much with too many other BPAs, okay, what do you want to do? And where do we go from here? And how else might we do it? There are a lot of ways to do this, but on the other hand, I have not seen it done in ortho.
Yeah.
Right. And so primary care is just, it's the tip of the spear for everything. It's where everything, rubber meets road. So primary care, to me, it's just a really, really tough place to try to make something happen. So I think that it's not clear to me that it will be the same in ortho as in primary care. Hope that answers you.
Yeah, it does. Thank you so much for sharing that insight. Yeah.
We're at 8:30. Anybody else have maybe one more great question? I know mine was going to be about, we tried to do a similar sort of study here, not quite as extensive, but a quality improvement study about false prevention using Otago. And our issue was the perceived idea that physical therapy was too expensive with the copays and everything. So the physicians were interested in having the patients do exercise, but they wanted to they were more willing to refer them to personal trainers and other things because of PT being too expensive and the copays. Have you run into that barrier and bias, and do you have some suggestions for that?
I know that's an issue. I think that one of the things that I'm really interested to find out is if that is prominent in this environment, in this health system. We'll see. I mean, copays have been a really big barrier for people to uptake. But again, I think that that's going to be a place where we could create some strategies. These are the highest risk patients. So it doesn't just automatically go that they should be in community exercise programs. So I think that's what we're going to need to struggle with and see how much of a problem that particular barrier is in this environment.
Yeah.
I mean, in another study that I did, which is not in this area at all, a health system changed the copay based on health services data about physical therapy intervention. So it's possible that was an insurer. It's possible that those things can happen, and in an environment where you have connection to payers and health systems, it's a place where that could possibly get resolved.
Yeah, good idea. Well, thank you so much, Dr. McDonough. It was a very interesting journey that we saw you take. And thank you for telling us about Learn and CoStar. So thank you all for coming. And we encourage you to keep in touch with us at RIPPT. And now that you signed up for one, you'll hear more, get more emails about our events. Good night, everybody.
Bye-bye.